Today, we're delighted to have Martin Hayes with us. Martin's a graduate in politics and economics from Queen's University in Belfast, and he also holds a master's degree in health and social care management from Ulster. Martin's worked in the health and care sector in Northern Ireland for 29 years, and the past 24 years, although he doesn't look old enough for it to be 24 years, has been spent in the field of primary care, the last 5 of which he's been leading the introduction of integrated care partnerships in Northern Ireland. And he's specifically going to be talking to us about a commissioner's interest in ECHO. We're delighted, as those of you who will know, that we have ECHO across the UK now, to also have, speaking to us today, Sam Kyermateng, who's the medical director at St Luke's in Sheffield, and also Steele, who's the CEO at Highland Hospice, bringing their perspectives of why they've engaged with ECHO. And then it wouldn't be ECHO without asking Professor Max Watson, to sum up and to take questions at the end. So I'm aware we've still got people joining us, but we'd really like you to welcome Martin Hayes.
Okay, good afternoon or good evening, everyone. Thank you to Carol and the team at Hospice UK for extending an invitation to me. It's good to see, as Carol says, a number of you have stayed behind, and hopefully I'll be able to shed some light on Project ECHO and what we're doing within Northern Ireland, and hopefully then there'll be an opportunity for some discussions. As Carol said, my name is Martin Hayes. I have been working in the health service in Northern Ireland for quite a while now, and leading on the integration agenda, and specifically integrated care partnerships. And it's that piece of work that sparked my interest in Project ECHO when I first heard about it about 7 years ago, and I've been actively involved ever since. So I work hand in hand and in partnership in Belfast with Max and the rest of the Hospice UK team. And I'm also delighted to say that I'm working with Hospice Isle of Man, and Mills and some of the team are here, I think, in the context. And I'm working with them in terms of rolling out and establishing Project ECHO in Isle of Man Hospice on the island. I thought I'd give you just a minute on our journey in ECHO in Northern Ireland, and again, it is quite literally just a minute because we've been told to keep it brief, but really our interest in ECHO started probably 5-6 years ago, and we dipped our toe in the water, and then in 2015-16 we made a bid to our then transformation monies and secured resources to have a go at a pilot. So we had 5 knowledge networks up and running. Fast forward that to 2017-18 this year, and we've now over 30 knowledge networks up and running and a new partnership established with Hospice UK. Some examples of our networks, and again, you'll find much more information on these on our website, but you can see there's quite a breadth there. So we're absolutely involved in palliative care and end-of-life care, but we're also working on areas such as elective care, practice-based pharmacies. We're using ECHO in our prison health services in Northern Ireland, in community and nursing, transformation in nursing homes, diabetes, and you can see the list. So I suppose, the topic of today is, so what? Why would the Health and Social Care Board in Northern Ireland bother with ECHO? Why would the Department of Health in Northern Ireland bother with ECHO? Well, the reason is pretty much the challenges that the health and social care system is experiencing. Northern Ireland, like anywhere else, is under pressure. We do a lot of things incredibly well, but there are opportunities to improve. And we've had a number of reports over the years suggesting ways that we might do that. Change is hard, however. Finding someone actually to lead that change can be even harder. That is the real challenge. And to be honest with you, people are so busy doing the day job, why would they do something else? Well, that for us is where Project ECHO comes in. We very much see ECHO as an opportunity for scaffolding around which to build safe service transformation within Northern Ireland. There's a lot of talk about co-production and co-design. ECHO, at its heart, is co-production and co-design. And that's the environment within which the Department of Health and the Health and Social Care Board really want to build transformation. When we meet with our network leads at their induction day, as I say, we've now over 30 of them, the first thing we ask them is, what does good look like? What does good look like in your service? We have a conversation with them and we realise and accept that it's always a bit of a balancing act. You have challenges of patient experience, of quality and safety on one hand, we have targets and performance and the economic pressures on the other. In the midst of all that, you have the noise of the political agenda and all of the challenges that go with that. ECHO is a safe space to have those conversations. ECHO is a safe place to drive that conversation. So when they ask us, why do we bother, and what opportunities are there for you guys then? How would you engage commissioners if that's the route that you want to go down? My first point of advice is always work with the willing. Identify champions, clinical and management, and constantly talk to them, and talk to them about what good looks like. What is it you're actually trying to do? Importantly then, get buy-in from the health authority and commissioning from the outset. Link to other people's strategies. ECHO isn't about ECHO in itself. ECHO is an enabler for other things. So you need to identify what are those strategies. Use them as the hooks to get ECHO in the door. Be it STPs or CCGs or ICPs or ACOs or TLAs, whatever three-letter acronym is flavour of the month. We all know what they are, and we all know that's key. The opportunity is to get in there and sell the vision and sell the benefits of what ECHO can do. ECHO is all about getting things done through people, and that's what commissioners and providers want. So where's the benefit in that? It speaks for itself. One of the big pluses we had in Northern Ireland was from the outset establishing a project board or an ECHO strategy group. And again, my recommendation to you would be invite key influencers and champions to join that. It can be a real centre board when the waters get rough, and they will get rough, and it's a real opportunity to build good governance around ECHO and how you're using it moving forward. Other key opportunities are to speak at commissioning events and showcase ECHO. People don't really understand it until you experience it. I'm not sure how many of you in the room have experienced ECHO. But once you're there, you've drank the Kool-Aid, as Max would say, you really get it, and you can feel the energy in the room. But you need to bring people with you in that journey. Other advice would be invest in evaluation. Commissioners, just like anyone else, aren't in it for the love of it. They need outcomes. They need evidence as to the benefits. That's what we're investing in Northern Ireland, and we're sharing those outcomes, again, through a good PR and communication strategy. My final advice on this front would be manage expectations. Everyone wants things yesterday, but ECHO moves at the speed of trust, and sometimes trust can be hard-earned, and once it's there, it's well worth it. But don't rush things. Don't build and overpromise. Really manage those expectations and keep yourself just below the radar. So about our approach then in Northern Ireland? We talk about ECHO on a 4-year cycle. Level 1 are our newbies, just when the community of practice is establishing or just about to establish. Level 2 then is when that network is developing. And level 3 is when it gets really interesting. Year 3 we begin to explore. The community's established, the trust has been built, the relationships are there. That's when we begin to explore, how can we think about doing things differently? What are the ideas that are coming through from the network, and how can we incorporate those into the everyday work, into job planning, into the development of services, into a new service delivery model. Year 4 then, that service is developed and ECHO is continuing to provide that support, a new way of working. I know it sounds maybe a bit far-fetched to some of you, but I'll give you an example of where we've done it in practice. So again, from our optometry perspective, community optometrists linking with experts in secondary care. We got them together, we developed the network, we had a conversation around what are those challenges, what are the opportunities, how could you do that differently? And in level 3 then, and now, we developed a local enhanced service, again a parallel process, running alongside ECHO to support transformation. A way of rewarding community optometrists for managing patients in the community, closer to home, that were previously treated in secondary care. Patients with macular degeneration, glaucoma. Safety, quality, productivity, flow, reduction in waiting lists, which is completely evidenced, we have the numbers to support it, and care closer to home. A win-win. That said, as it says along the bottom there, transformation looks different in every network. Again, back to the conversation and the idea around co-production and co-design. What does good look like to you? The beauty of networks, what more can I say? Across the globe, I think everyone realizes the move away from hierarchical structures and organizational silos to networks, to matrix working, and the opportunities that that presents. That is ECHO, and that is the beauty of ECHO. I'll just finish off with this slide. Again, I wish I could claim credit for it or suggest that it's an old Irish proverb. It's not. I'd pinched it from some of our South African colleagues the last time I was in Albuquerque. But again, I think it sums up ECHO completely. If you want to go fast, go alone. If you want to go far, go together. And that opportunity for co-production, co-design and trust is what ECHO is all about, and that's why it's appealing to commissioners and providers. Thank you.
I think the most rewarding experience has been the whole interaction between the spokes and the hub, and also the spokes themselves. Community pharmacies can be quite isolated from training and also from each other, and it's clear to see the benefit they get from learning and interacting with each other. The pharmacists all have similar experiences in their palliative role, and so being able to discuss any issues with their peers and how to resolve them is great. The mix of presentation and case studies is ideal, and the spokes and hub have all engaged with this process. I know I have learned a lot from the case study presentations by the spokes, which have all stimulated a lot of conversation within the group.
Our ECHO network is in the South Eastern Trust, and it's about palliative and end-of-life care for community nurses. So our spokes are our community nursing teams, and we have asked them for their input into the programme. It's been good in that there's a lot of joined learning, and that we learn a lot from the district nurses as they discuss their case studies and bring in their experiences from actual practical experiences and how they relate the learning to their practice. So it's been a very good learning curve in that way. We'd like to encourage more district nursing teams to join the network and to kind of spread the word that that we're doing it and that they can join in. It's great that they have their iPads and can join in wherever they are and out in their teams. So we want to encourage more uptake of the ECHO programme.
The Dementia ECHO network is about developing a community of practice in dementia care. The network members include dementia specialists who work in memory clinics and community dementia teams, as well as general medical practitioners, pharmacists, community health and social care staff working in the health and social care trusts, as well as nursing home and daycare staff from the independent sector. Our network is looking at dementia practice across the dementia journey, also referred to as the dementia pathway. This means the network will look at practice from the initial presentation of symptoms of suspected dementia through to management of the condition. As dementia is a progressive condition from which there is currently no cure, the network will also consider the end-of-life needs as part of the dementia pathway.
Good evening, folks. I guess my brief for this bit was why would the Chief Executive get involved in this namby-pamby stuff? Basically, I suppose we're an early adopter of ECHO up in Highland. I was actually tracking back. I was thinking we've been doing ECHO for about 3.5 years, and I was thinking it was this conference 4 years ago actually when I was down, and my lead consultant Jeremy Keane had been chatting about this thing ECHO and this guy Max in Northern Ireland. Anyway, came down to the conference and heard Max talking about ECHO, and that was 4 years ago. And I remember actually texting Jeremy from the conference hall, just saying, just get on with it. Just do what you need to do to get this done. So my kids would find it very amusing if I was describing myself an early adopter of anything that involved technology, as someone who still plays music on CDs. I'm not ready for this digital stuff yet. So why were we an early adopter? And it'd be great to have an enlightened commissioner, such as Martin. I don't have one of those. So it was very much not finance driven. Nobody has yet funded me to deliver ECHO in Highlands. And to a certain extent, I don't think they should. It shouldn't really be finance driven. It should be strategy driven. So just to start with, talking about finance, part of the problem is that there are no resources, or there are no additional resources available. If there's additional resource, then something else has to drop off. I was thinking, maybe this isn't such a good analogy. So I think somebody sort of famous in history said, when there was no resources available, let them eat cake. And you know what happened to her. But in essence, that is what ECHO has enabled us to do. We have had our cake and eaten it. So I suppose our starting point was that we had a problem to solve. And I suppose 4 years back, we were really sort of focused on trying to develop a new strategy for the hospice. You've seen these stats. Yes, huge additional demand in terms of end-of-life care, and there are limited resources to respond. So the solution, what they're saying, we need a solution if we are to remain current for the future problems. So but it's a huge challenge to meet that increasing demand with no additional resource. And the solution is obvious. Yeah, build a bigger team. So build a bigger team, but don't increase your staffing costs. That's what it's about. How do you do that? This is Highland. We're just at the top of the dark blue bit. That's Inverness. That's where Highland Hospice is based. To drive north and back is a 6-hour round trip. To drive west and back is about a 6-hour round trip. To drive to the south, well, you don't. We just don't go there. But we only have a population of 220,000 people, so it's a very, very dispersed population. And sometimes I think people see Echo as something for this landscape, and there's no doubt it's fantastic for this landscape. But you know what? If you're in Edinburgh, if you're in Birmingham, you drive from one end of that city to the other end of that city, round trip, you're still probably talking a couple of hours. Travel is a hugely time-consuming thing, and it's actually rubbish for networking people, because all it does is it takes you to where they are. It doesn't help them network then with other people in their area. So Echo is an obvious solution for us. So that's where we are, just where the Inverness, where the arrow is, and that's the range that we now cover. We actually have some little flags south of the border in Cumbria, but don't tell anyone. And also we've got Shetland up there. We don't cover Shetland, or Stornoway. That's got a separate health board, but who cares? It's distance is no object. And it is interesting the way it just completely tears away barriers, because actually the issues in Stornoway are very similar to the issues in Isle of Skye. So why wouldn't you want to get these people together? So we now have 96 healthcare sites that we network with across the Highlands. We have our care home network, we have our community pharmacy network, we have our rural GP network. We're just about to start up a care at home network, which we're quite excited about, because that's a hugely difficult group to network with or do any education work with. We're just about to start a child bereavement Echo. We have a Crocus child bereavement service, and Hannah, service manager, will be echoing with school teachers, because who better to support children who have been bereaved than school teachers that are interested in this subject? And there's plenty of them, but they're difficult to reach. But our care home Echo has been the one that's been longest running, and that has developed a genuine community of practice. There are about 20 care homes that we're currently networked with, and to some extent we're hearing less and less from them, because they are networking with each other. They learn far more from each other than they probably learn from us now. And in many of these care homes, they don't get opportunities to network and communicate and learn best practice of each other. And across this kind of area, that's massive. So, I mean, to put it simply, Echo has been the most transformational thing we have done within our hospice. And what did it take to do it? Mainly just the large spoon of belief. As I say, I think if you're money driven around it, I don't think you'll succeed. I'll speak a wee bit later. I think we are bringing money in now, because we've proved the concept. Everyone's talking about what we are doing because it is so successful, and other specialties, as has happened in Northern Ireland, are starting to get interested. But fundamentally, you've got to believe that it's going to deliver better care in your area, because it needs the clinical team. I can provide the resources, but it needs my clinical team to be enthusiastic about it. But the reach that we now have is massive. Jeremy Keane, our lead clinician, continues to lead the project, but we have 3 other docs as facilitators. Hannah, our cruise bereavement service, is a facilitator. We have a couple of our nursing team are facilitators for ECHO. So it has just grown through people seeing the benefit of it. And it's just the absolute best way to spend your time if you want to increase the reach of your team. And we have a huge team in the hospice now. You know, we used to only have 90 odd staff. We've doubled that, you know, because the folks within the care homes and community pharmacists, they feel part of our team. They feel connected to the hospice. We get regular phone calls. It's not all on echo because they feel part of that team. So that is the key. If you can sell that this will deliver benefit, then you will deliver echo, because nothing else really costs money. The technology, we all have it really sitting around in our hospices. It takes a little bit of administration, a little bit of organisation. But when we started up, it was just people with the belief in the hospice that started doing it. We've only really now invested in a small amount of IT support and some admin support. But other than that, it's just changing working practice. It's just a better way to work, and that's why it's been successful. So, as I say, the return on investment is massive. From a delivering palliative care, it's hugely successful. We have a far bigger team of people that we know are delivering good quality palliative care in the Highlands. The efficiency gains are just obvious. So, I mean, from a commissioner's point of view, it's what better, more efficient way to work. And I think the last one is we are delivering far more, but it's not a project. It's not a project that we have got additional money for. What it is doing is protecting our resource. You know, and I think that's just as important as finding new money. It's finding ways that you can demonstrate that your delivering greater value. You cannot afford to cut our funding, because you wouldn't want us cutting ECHO, because that's a massive reach. So it is just a massive delivery with basically the resource that you've got. As I say, we're now moving into, we've got ophthalmology interested in Highland. We're now delivering training as part of the Super Hub. Scottish Government have funded us to deliver the training. So money is starting to come. And I think, as Martin says, that there's a bit of patience involved. But to prove the concept, to show that it works within the hospice environment, you know, shouldn't require money. It just requires belief from your staff. But once you get that, then if you want to move out and seek commissioning for other work that might not be directly hospice work, but would benefit the organisation and make the organisation more valuable, then that will certainly come eventually once you've proven the concept. I'll leave it there. Thank you.
In 2016, we took part in the ECHO project, which was run by the Highland Hospice. I'm a care home manager of a 10-bedded unit. I had other members of staff coming to the video conferencing as well. We had 10 sessions. There were different subjects. Each of the subjects was very relevant to the care home. There's always somebody that fits into one of the categories, whether it's end of life, pain management, reduced mobility. They were really excellent educational sessions. There was always a professional there giving us a talk about, you know, current research, and we just found the learning from that was invaluable. We could take part in a case study. If we had somebody that we wanted, we knew in advance, we could prepare a case study and present it with a question around the case study that everybody tried to come up with a solution or something to help us with that. Each of us that took part in it found it just really, really useful to us. And then we shared our learning experience with our other team members. So we're very happy to take part again this year. So thank you for letting us take part in this project. We're really enjoying it. Thank you.
I am a community Macmillan nurse based in Inverness. employed by NHS Highland, and I was involved with Project ECHO for the first term, which was run by the Highland Hospice. That started in September of last year, 2016. For me, the fortnightly sessions were most helpful because it allowed me to connect with a lot of my Macmillan community nurse colleagues throughout NHS Highland. You'll appreciate that's a very widespread area, and we don't all get to see each other and know who each other actually are face to face. So for me, it was really good being able to connect with them, hear their stories, listen to some of their concerns and understand some of the work that they do in their different areas.
Hi. So I feel a bit like a Russian doll. I feel like the kind of bit inside the middle. And I suppose in a way, I guess I kind of am, because, you know, we've had on the outside, we've had a really big strategic view, and actually why strategically we want to do this. You know, we've had our executive view about why we want to do this, and now I'm going to kind of give a clinician's view on why we want to do this. And for all of my colleagues here, you know, what the patient needs, in other words, the clinician's view, is really at the heart of what all our view is. So I'm going to give you a little bit on the clinician's perspective, and I'm going to try and go quickly because I have a tendency to overtalk. Okay, so what is it that drives me? What is it that drives us as clinicians? Well, if I count myself as a clinician and as a lead clinician, I mean, how many people in the audience would put your hand up and just show me, are you clinicians? Or are you leading a clinical service? So there's a good range of people who are in that situation. And the things that drive us are fundamentally the same things that drive the big strategic agenda. We have an ageing population. We have increased need, increased complexity. We have an attrition rate in general practice that is creating challenges for our colleagues in primary care to meet the needs that they would like to meet. And we've got challenges around nursing, which we're trying to address, and obviously the increasing demand statistics that we've been talking about. But actually, what I also think as clinicians, as well as addressing the clinical need, we're also there to operationalise kind of strategy. Really, that's what we do. We turn big, high-level strategy into something that happens on the ground. And when you look at the NHS England service specification for what specialist palliative care teams are, what it's describing really is clinicians playing a lead role, really in developing service, changing practice, delivering guest practice, and supporting our colleagues in a whole range of different settings. It's fundamental to who we are and what we do as clinicians, as well as addressing the complexities of each individual that we care for. I think also strategically, one of the things that Martin raised was really about the strategic requirement for us to address need. And when I think about our charitable objectives, which will be pretty much the same as everyone here's charitable objectives as a hospice, it again goes to the heart of us trying to engage. And we're trying to operationalise our strategy as clinicians and make that touch people's lives, increase our reach, conduct research and evaluate a process that makes a difference to people. And the same is for our vision and our mission. And I would say that's probably the same for everyone in this room, as clinicians, as executives, and as commissioners of service. And how we responded to this increasing challenge and this increasing need in a range of ways, but bolded at the bottom for us was Project ECHO. It was about supporting ourselves and supporting our partners and developing partnerships that allow us, as Kenny said, to expand our team. And that's the only way we can address the challenge that we all face through collaboration. We were inspired by the early work around how we reach out to palliative care teams that started in Northern Ireland, and how it connects geographically distributed teams, and I think that's something that may be relevant to many of us in the room. When we work with greater confidence when we don't feel isolated, when we work together. And ECHO brings that to us. It makes us part of this community of practice and this team that makes a fundamental difference to how we practice on a daily basis. We've been emboldened by our links with Health Education England, working across Yorkshire and Humber. So that's the Yorkshire and Humber chapter of Health Education England. And like in Northern Ireland, their confidence in a process that seems to solve many of the problems that they expect to have. Again, we can't overpromise, we don't want to underdeliver, but actually their confidence in the process, in funding our pilots and getting us started and growing, has been enough for us to think that there is really something to this, and it's added legitimacy to my voice as a clinician. When I go to speak, we talked about, Kenny mentioned it's great to have an enlightened commissioner in the room. It's similarly, as a clinician in this room, you might need to go back and convince your executive or your board and then your commissioners. So it's great to have an enlightened executive. And it's great to have an enlightened commissioner. But someone has to start that journey in understanding the value of ECHO to you as clinicians. So we started our journey with a pilot project, again in nursing homes. That's our initial project. We're on our third cycle, I guess you could argue our third level, and that's grown over the course of 2 years. And that grew rapidly from 10 pilot nursing homes to 20 pilot nursing homes to now 33 of the nursing homes that are in our city out of 46 are engaged in our ECHO. That's not because they get money. It's because they are volunteeringly, they are actively recognising the value in being in a community of practice in the same way that the video testimonies from the Highland Hospice described. They're feeling something that's coming to them. These are clinicians on the ground. Whether they are registered workers or unregistered healthcare providers, they are finding a value in coming together and sharing knowledge. And I would say that that is really one of the key motivators in ECHO. And this has allowed us to gain confidence and grow as clinicians, again, to shrink this growing world that we live in, to manage the knowledge gap that's increasing as medical knowledge increases. And that's allowed us to think, like the Highland Hospice, like Kenny said, into domiciliary care. And we're actually starting to reach out to that sector and trying to find ways to connect. And then also to our local ambulance service. And when I say our local ambulance service, it's our regional ambulance service. And they're actually starting to find a way of engaging with ECHO that has been exceedingly powerful in how they can actually start to think about end-of-life need and how they can change practice across the Yorkshire and Humber region. And that's because they've seen the power of what ECHO can do in bringing clinicians together, sharing knowledge, gaining confidence. And we see other opportunities in primary care and how we link in relation to end-of-life care, complex care management. We all know that our patients are increasingly complex and challenging, and actually sharing that knowledge confidently between us makes a massive difference in addressing some of the real challenges that general practice, district nursing face. So we see an absolute opportunity in the way that ECHO has already established in other ways. And then at our interface, again, with paediatric palliative care, we had a great talk in the plenary before. And, mental health, learning disabilities, dementia, the opportunities grow and grow. And to a certain extent, the limit is kind of your imagination, but you have to pace it. I don't really need to talk about the core principle, because I'm sure you've seen them all already. But essentially, what ECHO has done is a methodology that provides us with a genuine framework that is established into how we can deliver and engage and develop communities of practice to improve what we do. And that framework is based on some of the things that you see here, or all of the things you see here. And it really provides an opportunity to create both kind of a framework for effective leadership amongst our community of practice, but it also puts everyone on the same level. The mantra that we always hear and we always say is everyone is a teacher and everyone is a learner. And that absolutely is the principle of ECHO, and fundamentally we live it in each ECHO session that we run. These are just some images of our ECHO teams engaged. And we've had some really exciting things in our ECHO happen in the background. And actually, it is a real community of practice that's developing, from our first ECHO cat walking across the background in the screen, and someone zooming in from home, to someone echoing on a bus travelling on a coach travelling to London because they were desperate not to miss the session. We've had people echoing in from home because they ambulance service clinicians who are so desperate for the opportunity to engage in education that they're coming off a shift and they're taking time to sit and engage in this. And so if we can provide an opportunity, absolutely, it drives clinicians because they get the knowledge and it builds the confidence that we need. These are just all images of our experience. We did, as part of ECHO, part of the evaluation process is to try and understand really what clinicians need. What are they needing? Well, really, so we did this evaluation as part of really trying to assess as we go, what is it that people want from ECHO? What are their learning needs? What's the learning needs analysis? What's driving their attendance? What do they need us to deliver on? And this is a word bubble. It's one of our new favourite things, word bubbles or word clouds. And this is what our ambulance technician says they wanted. They wanted to improve their confidence. They wanted to improve their knowledge. They wanted provision of psychological and emotional support of each other. As clinicians, that's what we all want, really, in our daily activity. And to help us deliver better patient care. And so you can know you can manage a patient in the situation where they are. And really, our paramedics kind of identified these specific learning needs which have driven their programme. I've kind of come pretty much to the end of what I've got to say here. And there's just one thing I just wanted to share with you, which may or may not be relevant. I'll let you decide. But we ask our ambulance technicians on our ambulance echo, you'll see something from our nursing home team here, but we ask our ambulance clinicians, ambulance service clinicians, to distinguish 3 points that they take away from the echo, things that they've really found valuable. And Kirsty, one of our ambulance technicians in our end-of-life echo for them, kind of came back with these things. With regard to the last session feedback, the 3 things I learnt from it, it's hard to distinguish 3 points really, but 1, the information has given me the confidence to have an open and honest conversation with palliative care and end-of-life care patients. 2, I now know the politically correct phrases we are allowed to use that I have seen as acceptable when communicating with patients and families. I missed that echo. I wish I knew the politically correct words to say. 3, I've been able to apply both of these into practice since the session, which I wouldn't have done otherwise. Both patients were palliative care. The first patient, my colleagues were a little reluctant to ask about the patient's cancer, but I had the confidence to have an open conversation which led to ease for the patient and ourselves, including asking if the patient had a DNA CPR form. The second patient asked if they were dying. Without this course, I would have not had any idea what to say for the best, and thankfully I did. Thank you so much for all of what you're doing. It's really helping my practice, and I'm passing information on to colleagues which I have learned. To me, that's a really powerful representation for clinicians about what they're doing in their daily lives. And if you think about the only way that we're going to solve problems is to evolve, there is this preserve, kind of evolve, all of these key things. Well, this is preserving what hospice care is, which is reaching out into a wider team, and it is evolving to use new technologies and methodologies to do what we do best across a wider team. Thank you.
It's given us a lot more information about different practices and a lot of support from the speakers and also the other colleagues that was involved from the different homes about their experiences and the tips and advice, and to try different things and different ways of overcoming difficulties.
So participating in Project Echo has been really important to me, just for the fact that I feel like I'm part of a large community now. I've made some friends, I've listened to other people's experiences and how they've dealt with it, and it's challenged my own practice and made me think, oh, actually that would work really well in our environment. And also being able to share my own knowledge and saying, actually I've dealt with this and we did this, and it makes you feel like you're not alone as a nursing home nurse. You get bad press, you also get socially isolated, so it's having that little support network is quite lovely at the end of the day.
Yeah, well, it's the first time that I've been part of any virtual training before, so I wasn't quite sure what to expect. It was perhaps a little bit daunting, if I'm honest. But you soon forget about that really when you sat there that you're in front of a webcam. It was really good just to be able to come straight off the shop floor into the training session without having to go anywhere else, and just to be part of it with people from other homes, to be able to hear their experiences and just have some open dialogue really with them, which we don't very often get the chance to do.
It was really great, very informative. It makes you realize that there is more to end-of-life care, because generally we say we make a care plan, end-of-life care, and how to deal with residents who's dying and how to deal with relatives. But there's more to that. You have to provide care, at the same time dignity, not only for the relatives, but only for your residents also.
To definitely take part, and one of the things would be to put that time aside for when it is the echo time, because it is invaluable to build up that network of people and resources.
So what I would definitely say to anyone that wants to take part of Project Echo, to do it, just for the fact that it's one of those experiences you feel very nervous about because you're on camera, but then once you get into it, you're like, actually this is quite fun, and it builds a lot of confidence in you as a practitioner, as you as a nurse or even a carer, and it makes you realise you actually know a lot more than you originally think, and it makes you have a little bit more pride. Like, actually, yeah, I'm a nursing home nurse, but that's actually ace. I can do a lot more than people realise. And it's definitely benefited my own practice. It's gave me a lot of confidence and to progress my own career.
I would say, yeah, definitely. It's definitely worth the effort. It takes a little bit of time sacrifice, and that can be quite hard sometimes to buy the time out of the day. But it's really worth doing that. And we hope to definitely be part of the next phase.
I really advise all the care homes to attend, because at first, to be honest, I'm not interested, because what is it that, you know, what is the difference? We provide care and dignity and everything, but there is a lot more to learn, to be honest. As you go along, you meet loads of patches that you have to deal with. It is very good, so I really would like them to attend.
When we were planning this session, we were conscious that this is our 4th year of ECHO at Hospice UK Conference. And so we wanted to kind of really focus on the experience of a commissioner. And our commissioner today said, ECHO moves at the speed of trust. A real wisdom, I think. And then we wanted a CEO who would bring his own particular canny approach to ECHO. ECHO is just a better way to work. Yeah? And then we wanted to get someone who's actually engaged in the clinical aspect of ECHO. And so Sam, very kindly, from St. Luke's, gave his experience and shared the experience of people who are regularly involved in ECHO, as did the others, the Northern Irish accents and also the accents from Highland. And so our approach today was really to try to focus on the practicalities of running echoes. Over this last year, Hospice UK, in partnership with our Superhub colleagues, we have trained some 18 networks across the UK. And of those 18 networks, 8 have already secured external funding to help them in their work. But they've also developed or maintained a real enthusiasm for this traditionally very old way of working. It used to be, it was Friday at 4 o'clock in your local GGH, and you'd go and you'd get a little bite to eat, and then you'd have a bit of teaching, and then you'd nab the local consultant, what should we do about Mrs. McGarrity? There were these existing communities of practice to help us in our ways of working. That no longer exists. But ECHO is a way of reconnecting those vital communities of practice. My recent classic story of being part of an ECHO was from one of the ECHOs in Northern Ireland, the Dementia ECHO. And it happened a couple of months ago. They were talking about a resident in a nursing home. And every morning she would scream for nearly 15 minutes after the nurses had got her up. And so there was a real debate about when should we introduce pain-killing medicines, so, 15 minutes before, 20 minutes before, all this debate across the network with the professor of geriatrics or old age giving his opinion. And they just were drawing it to a close when a nursing auxiliary from one of the nursing homes tentatively put up her hand. She said, could I just say, what we have found in our nursing homes with such patients is if we come in half an hour before they need to get the patient up, and we slowly have got the time to start to just move the fingers, then the wrist, then the elbow, passively take the body through a range of movements, then they don't need to use any medicines at all. She was the teacher. They were the learners. ECHO shares its knowledge right around the network. If you're into webinars, Zoom technology will be a real help to you. It's not ECHO. We're doing something different. We're building a community of practice across a network. Could I ask, how many of you have been in ECHOs or have seen ECHOs? Could you raise your hands? So some of you are complete ECHO newbies. We haven't been pitching today to you, but we would encourage you to go to our website. There you can see examples of ECHO in action and learn a little bit more about it. What we wanted to do with the remainder of our time before we finish, ahead of 6 o'clock, I've heard that message, is to ask you for your questions in relation to ECHO and running ECHO in your particular area. I wonder, would there be any questions out there? Yes. Could we get that lady a microphone, please? Thanks, Hazel.
Thank you. Just a quick question, really. I work at a small hospice in North Wales, and we're really interested in sort of getting engaged with ECHO. As a hospice, we don't have any internal IT support because we have that, all our IT systems are linked into the local health board. Is that a big stumbling block in terms of implementing ECHO?
Thank you. That's a really good question, really important. What we found initially, there was some hesitancy with our NHS IT colleagues, but that has been overcome. Sam, do you want to mention a little bit about Sheffield and working closely with the...
We've started working more closely, and we've supported the development of an ECHO hub in Doncaster and Bassetlaw, which combines an acute hospital foundation trust, a mental health and community trust, a CCG, two CCGs and a city council. And so they've all got their own statutory IT systems. And there have been some challenge about being able to access some of the resources. But it's actually quite simple, really about just, if you've got Wi-Fi access and you've got a dedicated computer, which the cost of the setup is really low, you can find a workaround that suits everyone, allows you to access it. So it shouldn't be a barrier at all. I think it just requires a bit of imagination. The actual training requirements aren't that great. You know, I think that it's expertise that I'm sure that you could develop within your organisation to use it. And then it's linking in with the people who work around you as part of a team. It's really doable.
I guess what we're saying, it is helpful. Well, the ECHO model has been developed. You having access to the personnel who allow the clinicians to do their bit. So you don't have to be the one who's also providing the teaching or the support and be guddling around with wires. Guddling, I think that's a Scottish word. Yeah. I think you understand that, because we've all been part, or many of us have been part of IT projects where the enthusiasm of the individual was thwarted by having to do all the different constituent parts. So the model suggests you really need IT support, that you need admin support. How that comes, it may be that one of your other staff is comfortable in providing that person there in the room to be able to switch on and off the microphones and that bit. But the thing we're fundamental about is that clinicians do the clinicians bit, letting somebody else focus on the other thing so that the project doesn't rise and fall on one person. But go for it.
Sam, I would just say, we've just trained 2 NHS palliative care teams in ECHO. So, I mean, they've very much come to us wanting to use it. So they certainly don't perceive a problem in terms of integrating it into their networks. And certainly our local IT manager in NHS Highland, we've had some discussions because obviously we are networking with NHS colleagues, and it's never been a problem. Yeah. So I don't see why it should be.
But that's actually really useful to know, and what we would recommend. Often NHS IT people, they speak really so much more effectively to other NHS IT people. And if there is an issue, then please speak to our NHS IT people in Northern Ireland or in Sheffield or in Inverness. They will believe them much more than they'll believe you, I'm afraid. That's the nature of it. But the portal has been opened for Zoom technology to be used all over the NHS. It is allowed. Please.
That this is kind of ECHO in action. This is kind of our community of practice, you know. So you've asked the question, you've joined our community of practice, and suddenly all of our hub sites are sharing our experience. So I think not only to the technical point, but this is how ECHO works.
Other questions?
Yeah, one here. I'm John Knight from Loris Hospice in Leicester. I'm just interested, you said now there's 8 ECHO projects that have got external funding. Can you say, is that all from one consistent source?
No, each one is different. Each one is. I've just given that as examples, and they have tied in with local areas. Like Sam was talking to you a little bit about. Do you want to?
So our experience has been working with our local workforce action board, and then Health Education England working across Yorkshire and Humber. And those 2 things have kind of allowed people to recognise how ECHO can reach out to and address some of the problems that they've got in their areas in hard-to-reach populations. And so we've had an opportunity there, our local workforce action board, and then also we've been supported by our local skills academy for health, who are also looking at trying to find ways to reach out to the hard-to-reach populations that we're supporting with ECHO, but they didn't know how to do it. And so somehow they've not only got the knowledge of what to apply for, but they've also got the expertise as to how to apply for it. So it's all about, again, having conversations with the right people.
Could I come back to that just a little bit about that? Because if remember what Martin was saying, there isn't much new money in the system, but there is money to do existing agendas. And ECHO can really help in achieving agendas in your area. And so if it's not seen as a bright, new, shiny thing, which requires bright, new, shiny money, but is a methodology to help you achieve what you're really struggling to achieve, we find that that is a really good way in. Martin, would you want to comment on that?
Yeah, you know, as I'd highlighted, you know, ECHO presents an opportunity. When you think about everything we try to do within health and social care, it's about doing things through people. And, you know, when the commissioner-provider split was introduced, if you like, it introduced a bit of a chasm, certainly within Northern Ireland, I expect within the rest of the UK, within health and social care. And we commission things in silos, we've developed silos, and, you know, there's traditionally been a very top-down approach to that. What ECHO presents and what the community of practice presents is an opportunity to break down those silos and an opportunity to have a conversation then around pots of money and resources and ways of doing things differently. And if you do that in a safe environment, it's well received. It isn't a threat and it isn't intended as a threat. So, you know, there's a real opportunity there. It doesn't always need new money. Sometimes it does need new money, but in the round, from a transformation perspective, there's always bits of money, and that's what I was trying to describe as a parallel process. If you can tap into that parallel process, if you can tap into that change agenda, there will be seed funding there, but what you'll need to evidence through ECHO is how you can move that from transformation to normal practice and embed it within service delivery.
Great. Okay. Oh, please.
Hi, my name's Karen Chumley. I'm Clinical Director of St Helena in Colchester. I just wanted to answer that question as well.
Please, thank you.
That we've been successful at getting 3 years' worth of pots of integrated better care funding for our ECHO. And I think it really fits in with the strategic aim of our STP development. It's all about integration. We're doing we started our ECHO work with a community of practice around care homes. But it does, I agree, it ticks those boxes about integration and the development and of STPs and transformation. I don't think there's a problem at the moment finding money for this kind of project.
Thanks, Karen. Thank you. Please.
Hi, I'm Kerry Harrison from Heart of Kent Hospice in Kent. We've registered and we're very, very excited to be joining the training in February. We have worked in collaboration with our community health provider, and they have appointed 63 end-of-life care champions within their existing district nursing team, and these end-of-life care champions have done some end-of-life competencies, and they are going to be our spokes so that we can actually support them and train them, and the Trust are paying us for that out of their training budget, and that's all agreed.
Fantastic. We're looking forward to seeing you too. But it's somebody else's agenda that is able to be fitted in, which really works. And it leads to one of the huge side effects of ECHO is improved relationships with others. We'd never really seen cardiologists in our hospice before or in our hospice environment. And now they're coming in and out of our ECHO offices in Belfast on a monthly basis. And they're realizing that we don't wear black cloaks and carry scythes around, which is helpful, I hope. Other questions? Yes, please, there's a question there at the back.
Hi, Anne Mills, Hospice Isle of Man. I've just wanted to highlight the way that we hope to use ECHO in the future. We signed up earlier in the year and had our training in Northern Ireland. Because most of our patients, Isle of Man has 83,000 population, most of our patients, when they're receiving secondary health care, they're having to go to Liverpool or Manchester. So we very much see ourselves being a spoke really to many other hubs, and we're setting up these relationships all the time now. Whereas we're a hub maybe on our island, and we have many spokes, and we're going to develop it right across the island and be the leaders in this innovative part of working towards integrated palliative and end-of-life care, as well as other integrated systems, you know. So I think it's about the size of it, though, is phenomenal. From the point of view of how we hope to work with our colleagues, and we're already in the paediatric palliative care network because we have isolated practice with very small numbers of children to work with, you know. So it's about the how it can connect Isle of Man to the rest of our wider systems to support and develop our practice, as well as us helping people to develop practice in our community settings, you know. So it's about the up and down of it all, which I find so exciting.
So that leveraging of scarce resource, be it a scarce resource which happens to be in Liverpool, which you need in the Isle of Man, or a scarce resource in Douglas, getting out there to Peel. Have I got the towns right?
Yes, you have.
Ah, star.
I'm really impressed. The only other thing I'd like to say, Max, is I think Kenny mentioned the evaluation, and I think we're very, very keen. We've been very, very lucky with funding for this project on Isle of Man, but we're very, very keen that we really develop evaluation tools to really demonstrate that this is an effective way of working. And I'd like to propose that with amongst all the hubs, we maybe set up a collaborative or a community of practice and evaluate this way of practice.
Just 10 feet in front of you, we have our first full-time ECHO evaluator in Janet Diffin. She's shortly to be joined by a full-time evaluator based in Sheffield. So we're putting together an evaluator community of practice. And between them, we hope they will produce really useful tools which networks can use if they choose to use, and that the evaluations will be appropriate for each network. You cannot evaluate ECHO. You can evaluate individual ECHO networks, and individual ECHO networks will be different, and the ways that we evaluate them will be different. But I also would encourage you to allow your ECHO's time to grow. As Martin said, it takes time to build trust in a new way of working. So if your first ECHO's goal is to reduce the number of attendances at your local casualty department, I'm afraid, and that's all tied into your future funding, that is going to be problematic. But in 3 or 4 years' time, I think you'll be able to do that, as our optometrists did in Northern Ireland. But allow your network time to build up the confidence in the whole network.
Max,
Simon.
Could I just also say, as time is I completely agree with Max. Time and setting realistic expectations is absolutely critical. I think the other thing that our experience has said is critical equally is as you build evaluation, actually those same links that you are seeking to develop connections to grow your ECHO are the same links that will enable you to evaluate your ECHO. So speaking to your commissioners who actually also want to see the outcomes, but might also be the ones who actually are the centre point because of law for all the data that comes in about what happens to the populations that your networks are trying to serve, they potentially have the ability to unlock the very data that they want to see. And so if you work with them and can describe that as a longer term goal, that's something that you can start to work towards once you've built confidence and faith in the process in year 3 and year 4 and so on. But it's kind of recognising that those are part of your strategic view from the beginning. You have to, at the start, having your eye on the long game and sort of trying to, so not to be squeezed into the position to deliver something unrealistic in 6 months of starting ECHO.
But it's just also to think of the poor commissioners out there. They're under huge pressure. When your ECHO is robust, to have a commissioner join your ECHO will give them a whole access to a whole range of information that they probably lack, and a reality to it. And that's where we're getting to that stage in Northern Ireland where we want to have the commissioners now start to join to find out what's actually happening along that whole pathway of care. And actually, we cannot deliver good quality care without commissioners in the same way as we can't deliver good quality care without good nursing auxiliaries, without good consultants, without good nurses, without good community nurses. We need the whole pathway listening to each other and learning from each other. It's kind of ironic that Northern Ireland is the kind of been the birthplace of ECHO in the UK, because we're known so much in Northern Ireland for the way we just love each other and get on so well. There was a question at the back. Could a microphone reach her, please? It's about evaluation. Great, thank you. We've got 4 minutes, is that all right? Do we have any other questions just across? Yes, please. Tracy, can you? She's just with you there. You're getting we'll get an echo here.
Hi, Max. It looks like we're a room full of Kerrys. I'm another Kerry.
Yes.
Obviously came down in summer. And we're one of those who have got commissioners and STP leads and LWAB kind of clamouring. They are really excited in Lincolnshire, even though we have tried to keep this under the radar. So the question that we are having, and I just want a little bit of clarity because I think that was really a really good question. We've had our STP leads ask how they can support us to scale up. So and this is one of the questions I was going to ask tomorrow, but as everybody's here and it's a community of practice, I thought I'd ask it. So that's the question. It's can we? They were asking if we can't train other people up for the time being, can they? It's the IT and the admin support that obviously takes the time, like you said. As clinicians, we roll in and we do our job, but they do the donkey work.
So our response to that is that unplanned growth is really dangerous. Mm-hmm. Planned growth is fine. As you know, we've been encouraging using the logic model in terms of evaluation. We would encourage you with your STPs to do a logic model mm-hmm. of where actually they want you and you want to go with regard to your ECHO journey in Lincolnshire. What your objectives are going to be at the end of year 1, your objectives by year 5, and you work it out from there. In order to achieve that, we will need this, we will need this, we will need this, by then. And that structured approach preserves the integrity of ECHO, because I guess what we don't want is ECHO to be seen suddenly as a lovely way of telling everybody in our STP area what they should be doing. Because it's much more powerful than that, because it's ears as well as mouth. And so it's preserving that community of practice, which works really well. But you can do that, but plan it. Yeah. Plan it in a structured. Does that make sense?
No, it makes perfect, and that's the bit. It's exactly what I can hear people wanting to take the ball and run with it, and it's like, slow down. It needs to be planned, but the answer's not no. We just need to do it with a plan.
We just need to do it with a plan.
Brilliant.
Yeah, maybe I could pick up on that bit, Max. I mean that you're absolutely right, and Max is right, because we've lived it in Northern Ireland, and Max has been there, and Max sometimes wants to run ahead, and I'm the person saying, slow down a wee bit. The opportunity there is to do exactly what you've done and what Max just described, and that's what I was trying to reference with regard to the strategic oversight group, or a project board, if you like. And no one wants to sit and be bored by Prince methodology to project management or anything like that, but it's absolutely essential. Get your stakeholders in the room, get an agreement, co-produced, if you like. Co-production isn't just about service users and carers and clinicians, and that's hugely important. Co-production is also about the providers and commissioners in a room, agreeing what good looks like, and having a really good understanding of where is it we want to go, where can we realistically go in the short term, the medium and the long term. Are we all signed up to that? Recognizing that it is about evolution and things change. But if you start off with that co-produced vision, get everyone on board and a very clear understanding of roles and responsibilities, that in itself allows you to manage those expectations, because, I mean, people are human. Everyone wants it done yesterday. And such are the challenges within the NHS and with health and social care and around. We all know, you know, that's the reality that we're facing. But this is very different. As you know, as I referenced earlier, this is all about trust, and it's about moving at the pace of trust. And I can't overemphasize that enough. And you know, if you have the right commissioners in the room, and if you're linking it to the right strategic goals, you'll get there.
The fact that Martin and I are such good friends was really helpful. That friendship developed through a community of practice. It's now after 6 o'clock. I am to turn into a pumpkin at this point, and you're all to leave very quickly, apparently. If you're interested in more about ECHO, there's a breakfast time session tomorrow. We'll be holding a kind of an ECHO, a non-virtual ECHO. You're very welcome to attend. Thank you very much for your interest. Thank you.